Hello and welcome, everyone. My name is Melanie Dizon. I'm the Director of Education and Content at the Davis Phinney Foundation, and I am here today to talk about Audie's programming with deep brain stimulation with his doctor, Dr. Shahed. How is everybody doing?
Good.
Great. So we're going to get into your story, Audie, and your experience with Parkinson's and leading up to deep brain stimulation and all of that. Right now, I just want to start with Dr. Shahed. Can you tell us who you are, what you do, your relation to Medtronic, and how you got connected with Audie?
Yeah, great. Thanks for having me on this program, Mel. It's good to do another program with you about deep brain stimulation, my favorite topic. So my name is Joohi Jimenez-Shahed. I'm a movement disorder specialist. I run the deep brain stimulation program at the Icahn School of Medicine at Mount Sinai in New York City. I have been working with patients with deep brain stimulation for most of my career, which is upwards of 15 years now. I'm sure I've lost track of the specific number, but it is certainly a big passion of mine just because of the really significant benefits that patients with deep brain stimulation can experience. And it's really amazing to be able to help these patients through their Parkinson's journey in such a dramatic way. So it's a big part of what I do and something that I really enjoy.
Great. Well, thank you so much. Audie, and you are with your wife, Cora. Thank you both for being here. Audie, can you tell us a little bit about your experience with Parkinson's, when it started, what were some of your cardinal symptoms, and how it's progressed over time?
Yes. By the way, my name is Audie Villaflor. I am 59 years old and underwent DBS surgery last November 15, the first part, and November 22, the second part of the last year. I started to experience hand tremor 11 years ago. That was 2012 when I was 48 years old. I noticed this after cleaning up my backyard and cutting down great tree branches around 3 inches in diameter. After a week, I feel that my right hand having spasm and suspected that it's only overwork. So I just ignore it. As days goes by, my whole right hand starts shaking. I decided to see primary doctor, knowing what will happen next. Then he referred me to a neurologist who had a private practice here in Brooklyn. He tested me with my own handwriting, tapping my nose to his finger back and forth, ambulating up and down in the hallway in his office, and to my surprise, to take a shot of vodka and observe me after a while if my tremors will stop. An actual test that takes place in his office after few visitations, he concluded that it was an essential tremor and prescribe additional vitamin such as vitamin B12. My tremors continue to advance, this time ineffective. My left hand arm, this time we decided to see neuro specialist at downstate. Dr. Bodis Wolmer in 2014, this time decided to see a neuro specialist downstate. Dr. Bodis Wolmer on 2014 sent me to Mount Sinai East to take that scan. At that time, I was 50 years old. And the concluding impression was that I have early stage of Parkinson. And I was told by the same doctor, but I'm still in denial. This time he started me in Cinemet and a Amantadine lower dose to come back to him in a month to see if there is some improvement, which has then. Eventually, due to stress at work, at times, sometimes I feel that the medication from Parkinson he prescribed was not effective and was before an intensity of tremors and shaking in my hands becomes worse, especially at work. And I let him know what I have been experiencing. At the time, he's then very close in retiring, and he told me, wanted me to see by a neuromedical specialist that work with my condition very well, and his Dr. Dapine Rubakis. Upon meeting her, I'm so pleased. She's very thorough. Then she discussed with me about DBS, but at the time I would say that I have hesitation, and even told her, my wife, that this is my brain and not theirs, so to say the least. My follow-up with her continues, and when I develop side effect with one of the medications, Siligilin, made me most pass out due to vertigo. When she changed this to Rytary, which I supposed to start 3 capsules 3 times a day, that time, and the work with me without side effect. One day I woke up and came up with a decision to go for DBS after telling Dr. Robakis of my decision. She conveyed to me that she's glad for me. Then she referred immediately to Dr. Joohi Jimenez-Shahed, and even told me that I will not regret my decision. From here, I would say begin my realistic journey, because I'm facing reality that I have Parkinson and I have to deal with it. Then in my first meeting with Dr. Joohi Jimenez-Shahed was eventful one, and she discussed about DBS.
And for the very first time.
And for the very first time, I listened with all my mind in it. Then we start the process of preparation, including meeting with the different neuro doctor team, such as psychiatrists, psychologists, psychoanalysts, eventually meeting with Dr. Feder Panob via Zoom as my surgeon, neurosurgeon. Then meeting with them and came with decision that I'm qualified for DBS. So last November 15 was my first DBS surgery, followed after a week for my second part of DBS, which is very successful surgery with no complication, no side effect, not even any pain or discomfort. During my hospital stay in the first day post-surgery, I noticed everyone was constantly neuro-checking me, such as asking my name, where I am, and what it is, and etc. And my first programming with Dr. Joohi Jimenez-Shahed came last December 15. I feel very much relieved as soon as they started and asking me if I feel something different. I almost told them yes, but now for the first time I feel that I have hand tremors are gone. No pinning sensation, no other pain whatsoever. I can't believe that it is an instant my tremor are gone. Deep inside, I'm so happy about it. Then looking back, I told myself why I did not do soon enough.
Wow.
Well, thank you. Thank you for that so much. It sounds like, it was kind of tough at the beginning. You were told you had essential tremor. I think that's pretty common with people in our community. And you also said, I think a lot of people experience that I'm overworked. I've done so much. This is why my body's reacting like that. Right. And it was good that you went back and that you kept going for it and trying to find the right people to help you out. Cora, what was that experience like for you? Were you noticing when he was noticing, or did you even notice it before?
I did notice it actually before, but I don't want to scare him because I'm also a part of a medical team. I'm a nurse, and then I deal with people with the same condition like him. So at first, when I first noticed the tremors in his hand while he is driving, because he likes to drive a lot, I saw his pinky starting to stretch up and down, up and down. Then eventually I come to the decision to ask him, what's wrong with your pinky? Is it painful? And he said, no. Are you aware that you're doing something to your fingers? Oh no, I'm just trying to relax my my fingers. So I'm thinking that this is his excuse. Then one day when we woke up, I told him, I notice your hands trembling around my shoulder. What's happening? And then he told me, oh, yesterday, remember you told me to cut the vine, from the grape tree? And I was so overworked. And maybe that was the reason why I'm having this tremors in my hand. So as days goes by, I'm trying to observe him. And I noticed that it's starting to get, more and more and more.
Yeah.
So I then decided we should see our primary doctor. So we went to see the primary doctor. And that's the part that, as we see Dr. Chong, he recommended immediately to see a neurologist, which happened to work in our hospital. So that's the story that he mentioned about the vodka thing. I thought it was a joke. I said, this is the first time I heard such thing. But he said, no, this is just to see if he is an alcoholic or not. And I was laughing. No, he never drink. He's not a drinker.
Oh my goodness. That's a new one for me. Didn't hear that.
Actually, I think sometimes when doctors are trying to distinguish whether somebody has a tremor that's more like essential tremor or more like Parkinson's, one of the really characteristic features of an essential tremor is that it does respond to alcohol. And so, I think sometimes doctors may say that a little jokingly, sometimes as a little bit of a test,
right?
Just to try to get confirmation about whether or not that's the case. So I think I actually do hear that quite a bit.
Okay, that's interesting. So that's definitely something different, right? If you drink alcohol, if you have essential tremor, it might calm down. Not the case with Parkinson's.
Not so consistently the case.
Yeah. Interesting. And so it sounds like, Audie, you had quite a few doctors that, you had and seen and that were taking care of you on your way to Dr. Shahed. And when you were thinking about DBS, what brought you to, did you talk to a Medtronic rep? Did your doctor, your surgeon recommend Medtronic? How did that work? And Joohi, what role did you play on his team as he was preparing for DBS?
Yeah, I think we probably followed the same sort of procedures that we do with all patients that are coming in inquiring about DBS. And often that first question and that first visit is mostly about, am I even a DBS candidate? Is this something to really think about? Can it help me? And so, irregardless of what kind of device you're talking about, I think that's just the fundamental question where a lot of people begin. And so it always starts with just a discussion of, what symptoms they've been having, how it's responded to medications, what are the challenges that they're still experiencing. And then, once we really kind of have that conversation about DBS and yes, this is a reasonable treatment for that individual patient, then we start scheduling them for the preoperative evaluations. And we don't really get into a lot of the discussion about the different device types until we're really kind of firmly committed that this is the path that we want to take. So I think what we did in Addie's case was to, when that first visit, we decided, yes, you've got really bad tremor. It hasn't responded to the meds. You've had side effects. This is a good treatment. Let's go ahead and get you scheduled for all of the preoperative assessments as he described to you. And then when he came back to start doing those, we usually test patients off medications, on medications. And once we've sort of seen what that part looks like, and we're even more convinced that this is really a good treatment option for them to pursue, that's when we usually talk about the device types. And I think that was the case. So we must have, I think, Cora, we gave you all the information about the different manufacturers, and we talked a little bit about the, different capabilities that the systems have, and, how we can use those different capabilities in our programming process. And I've had a lot of experience with sensing devices and really like what that has to offer in terms of guiding our programming and just sort of the overall, kind of programming experience for patients. And so mentioned that to them and suggested that if, they wanted my recommendation, then that's what I would ask them to consider. And that's, I think, how we ended up with the decision to go for a Medtronic device.
So for people who don't understand and, they're in this early stages of looking at this, can you describe like what the sensing functionality does and why you're a fan of it especially in this case in particular?
Yeah. So, for a long time, DBS has been around for a long time. And for the longest time, what we were really doing is just turning on the stimulator, delivering the electricity, and then measuring symptoms by examining our patients, right? So people are familiar with all the finger tapping and the tremor testing that we do, looking at patients walking and how that pattern changes. And really the programming process for, kind of traditionally up until things like brain sensing were available was this just kind of trial and error, iterative sort of process. So if you think about a brain wire that's being placed into the head, there's 4 different contacts on that wire, and you can deliver stimulation at any of those 4 places. And what we have to try to do is to test each of those out to say which is the one where the person is going to get the greatest clinical benefit and where we might have some limitations in terms of side effects. And then we kind of put all that information together and then decide, this is how we're going to do the stimulation. So that process, kind of pre-sensing and some of these newer technologies was taking, upwards of an hour and a half, maybe 2 hours in some cases, sometimes longer, depending on how well the patient tolerated it. And there was just a lot of like changing and testing and changing and testing, get up and walk, get back and walk. So, frustrating, maybe to a certain extent, tiring for some patients. And what we now can do with these sensing devices is, in addition to actually just delivering the stimulation, you can actually record the brain signals. And recording the brain signals gives us the opportunity to sort of see how the brain is reacting to the stimulation. And so then not only is it just, can we see the tremor get better? Can we see the patient moving faster and moving better? We can actually see the brain responding to it. And there is a lot of evidence that tells us that the places where we see this brain activity on the system after we've implanted it, can help guide us in that decision process. So now from a programming standpoint, we can cut our programming times down quite a bit. We can really hone in on where the patient needs to be receiving the stimulation. And it just makes it a much, kind of easier process, a faster process. And you get kind of double confirmation. Not only do you see the patient's tremor getting better, but you also can see the brain reacting in the right direction to the stimulation.
Great. And so it sounds like, Cora, that you and Adi went for was it a month post-op to do the programming was the first time? You said November to December?
Yes. From November 22nd, we came back on December 15th.
Okay.
The very first time with Dr. Joohi Jimenez-Shahed. Yes.
It's about 3 weeks. 4 weeks.
Okay. And what was the period between the surgery and your first programming visit like? How did you feel?
From the first surgery?
From the surgery to the first programming appointment?
Well, from the first surgery to programming, the first surgery, the first night of the surgery, when I visited him to the PACU unit, which is the post anesthesia care unit, I wake him up. He was sleeping. I thought he was sleeping. I called his name, whispering, and he answered. And then I said, oh my God, it's good. And I said, do you know who am I? And then he said, of course, you're Cora. All right, that's good. And then here comes the nurses, I think the residents, coming into the room, asking him what date it is, what's your name, any pain? No, whatsoever, none. I didn't feel any pain. I said, that's great. In the back of my mind, wow, that's really great. And I am observing his hands if they're having tremors. the tremors are gone. And then he said, I'm so hungry. So I asked the nurse if he could eat now because the surgery just finished, and he was
Right.
brought upstairs, and we could start with the liquid diet first. Okay. And then she put the I think it's a thick liquid or something like that, or a jello. He immediately grabbed it, and I'm looking at it, and his hands has no tremors at all.
Wow.
I said, oh my God, what a wonderful, what a miracle it is. Then the next day, the following day, he has to go home, and Dr. Panum says, you're doing great. You're absolutely have no complication, no side effects whatsoever. So you're good to go home. So we are all happy. And I started looking at him completely from the top of his head to the tip of his toes. Then they prepared him and everything like that. They wheeled him. So we are on our way home. And then I was so careful with him. I'm protecting him. Next thing you know, I saw him. He immediately went up into the car. I said, wait for me. I'm going to help you. He's already in the car. The next thing you know, I cannot wait to go home. So upon reaching home, he was on the phone with his friend right away. What are you doing? I'm calling them. I'm telling them I don't have any more tremors. Look at me. And he was so proud. He was so proud to tell them and to show himself. So in between that day, till the day we saw Dr. Joohi Jimenez-Shahed, had a little bit minor thing on the tip of his finger. But in the back of my mind, it's just normal because the transmitter is not really connected yet.
Yeah.
I remember Dr. Hadid telling us in one of our appointment with Dr. Joohi Jimenez-Shahed that after the surgery, there is some inflammation around the area of the brain. So naturally, the tremors will be a little bit suppressed. And then when the time of the healing is starting, then the tremors might come back. Mm-hmm. Remember, you still didn't have the transmitter program yet.
Right.
So, okay. So then I understand. And, mini, it's not a big deal. So when we reached Dr. Joohi Jimenez-Shahed and they start programming it, they were evaluating him and asking him if there's any pinning sensation or any indifferent sensation. And he said, none whatsoever. So I was amazed. I was so surprised. And I said, oh my God, look at these people, look at this technology, look at how God gave us this intellectual people, Dr. Joohi Jimenez-Shahed, Dr. Panum. They are God-given gift to us.
Yeah.
If we didn't see them, if we didn't pound them, what will be his future? What will be the future of my husband? That's what I was thinking. And then we continue to follow. Until I notice as we go by, a lot of improvement is happening. Once in a while, Dr. Joohi Jimenez-Shahed says to us that once in a while you will notice it's still on the process of programming. But then I notice sometimes when he's anxious, like now he's a little bit anxious, a little bit nervous. So he has a little bit of tremors, and that's expected to anyone, even with the normal people.
Right.
What more for him that he had a device.
Right.
So I give him an excuse for that.
Yeah. So Dr. Shahed, can you talk to us a little bit about what happens at that initial programming appointment?
Yeah. So just like they were describing, we usually wait about 3-4 weeks after the last brain surgery to make sure that all that kind of healing has happened. What Adi and Cora were describing there is something that we call a micro lesion effect, and it's exactly what Cora said. There's just a little irritation from having those things put in, so we want to kind of make sure that that irritation calms down. If we don't wait long enough for that, then sometimes it will sort of confuse our programming a little bit, and we may not kind of get on the best settings as soon as we otherwise would. So that's why we really wait that time. We ask the patients to come in off their medications. There's 2 reasons to do that. One is, of course, we want to see the symptoms getting better. So if you come in and you've taken your meds and your symptoms are somehow not as bad, because of that, then it makes it harder to know exactly how much stimulation we need to give you to control them. And then the other reason is that it's particularly important for the brain sensing, because the medications can also affect those brain signals. So we just wanted to be able to see the fullest extent possible what the response to the stimulation was without the influence of the medication. So that's why we do that. So the first thing that we do when the patient comes in is, of course, just make sure that everything went fine with the surgery and check them out, and we examine them and sort of see where we're starting. And then specifically with this Medtronic Percept device that does the brain sensing, I start by checking the brain signal. So we'll turn, the battery on. It's not, without any stimulation, and just check the brain signals. And we kind of spend a little bit of time, probably in Adi's case, it was probably about 15 or 20 minutes, just reading all the information off of the device. And then once we do that, then we can focus in on the area that we want to localize our stimulation. So remember, on those 4 contacts, we'll pick the one where we're seeing the most appropriate brain signals. And then we hone in on that area. We start with the left hemisphere that controls the right side of the body. And we just slowly start increasing the stimulation. At the same time as we're increasing the stimulation, we're looking to see that the brain signals are responding, and we're also looking to see that the patient's symptoms are getting better. So there is a little bit of examination that goes on as we're kind of titrating that stimulation. And we're also looking for side effects, which fortunately, as you heard, Adi didn't have any that day when we were doing that programming session. We saw a fantastic response in his brain signals, and we saw his tremor just kind of melt away, which was really, really amazing. Once we're done with the left hemisphere, then we go to the right hemisphere, which controls your left body, and we do the same thing, basically. Once we're done with that, then we kind of turn the stimulation on both sides, and kind of at what we think is the most likely, kind of helpful setting that wasn't causing any side effects. And then we make sure, just kind of big picture wise, whether the patient's feeling okay, whether they're walking okay, whether there's any side effects. And then that's sort of the conclusion of the actual programming. And then we just sort of talk about what we're going to do with medications after that. The last thing we do before the patient leaves is to actually teach them about their patient controller and how to use their patient controller.
Mm-hmm. So is it, in this case, it seemed, pretty straightforward, and it was a great effect for Adi. Is this typical, or is it sort of typical that, each situation is different just because every person with Parkinson's presents so differently?
Yeah, I mean, I think you're absolutely right about that. It is that, the patients may be different in terms of what their symptoms are. It may be different in terms of how, they're tolerating the stimulation. Sometimes if there's, subtle differences in where the electrodes are placed, we might have a few more challenges in terms of, side effects or testing for those, or really, making sure that we can get the clinical benefits that we want. So we might have to work a little longer or a little harder in some of those cases to kind of get it fine-tuned just properly. So, it is, like I said, a lot smoother, a lot easier when you have this ability to do the brain sensing, but I've certainly had some patients where we weren't able to take full advantage of that for one reason or another. And so then we had to kind of go back to our usual methods of testing. And I think that's sort of the great thing. There isn't anything, we can always fall back on our usual practices if that particular technology isn't helping us in the way that we need. Thankfully, that's not very often, but we can still get the results that we need to get for the patients.
Yeah. So how many appointments does it take on average to get things, dialed in so that, it's like maybe you don't see them as often?
Yeah. So my usual practice is to set patients up for 6 monthly appointments. So we do the first programming, a month later, et cetera, until we've got to 6 months. So I think it, again, just depends on patient to patient, how long it actually takes, but 6 months really kind of covers, the vast majority of patients to get it, as get it set where we need it to be. But the reason for that is that we can't just dial it up and get to the right settings right away. If we try to really go too high and we're not being mindful of how the stimulation may interact with medications, then we might end up with some problems there with both things kind of working together. We can't reduce the medications too quickly because sometimes patients will have significant either withdrawal effects or side effects from doing that too quickly. So there has to be this balancing. And so it's like a little bit of stimulation, a little bit of medication adjustment, a little bit of stimulation adjustment, a little bit of medication adjustment. And, you know, you get there eventually. And that can take up to 6 months. I think in Addie's case, it was like 3 visits. So we didn't need to
Okay.
take.
Real quick before we go to Addie, you were talking about side effects. So
Yeah.
what were the side effects that you would notice and say, oh, something's going on?
Yeah, I think side effects may depend on the part of the brain that is being stimulated. So there's 2 major brain targets. The one that Addie has is something called the subthalamic nucleus, or the STN. Some of the common side effects that you might see in that location are things like slurring of the speech. Patients may have some tightening sensations. It may affect their vision if, you know, certain settings are kind of too high or you're too close to certain tracts. What else? I said, changes in the walking and balance that are kind of like different from what we would expect in the Parkinson's itself. So things like that, which thankfully are all very transient, right? I mean, if we know that it's from the stimulation, we can just turn the stimulation down or adjust the stimulation. So that, you know, is sometimes, you know, it may be something that we run into, but it doesn't necessarily mean that it's going to be a problem for the patient.
Yeah. Okay. So Audie, it sounds like you are like the model patient and everything was going quite well. Can you talk a little bit about what that programming process was like for you the first time and then subsequent times that you went?
Yeah, the first time for my programming appointment, I noticed after the programming, I noticed when I sleep at night, I stop shaking my hand, both hands. It's a big help. But before that, before I sleep, I notice both of my hands are shaking. So for the first programming, it's gone.
Wow.
And we have a Christmas party with my family. And everybody was surprised.
It's a sort of
They said,
Thanksgiving
yeah,
Oh yeah.
very happy.
So did that just improve your sleep right off the bat? I mean, was that
Yes,
getting in the
until
way?
now.
Yeah.
Until now, I have
Wow.
a good sleep. Before, I cannot sleep without shaking my hand
First.
before. You
before
know,
sleeping.
both hands.
Mhm. Sometimes he will ask me to please massage my arms, my hands before the programming, before the surgery. I will have to, because he said it's starting to become spastic. So I have all sort of concoction, Bengay, Bengay, ice hat, all those things to, I said, do you have any pain? No, it's sort of like spastic. So would you please relax it? So I used to put it on both hands. So, and then until I will see him sleep. But after the programming, oh, my work is lessened because I don't have to do it every night
Right.
before you go to sleep.
Right.
Yes.
His hands are so good. He can be massaging your hands, right?
Yes, yes. Actually, sometimes I ask him to scratch my back. Now it's useful.
Right.
Before he will say, no, I can't do that. You know, I'm shaking. Oh, that's better because you don't have to do it.
Right.
Naturally.
You don't
It's
have to move.
doing naturally. I'm
That's
so
funny.
happy for him, honestly. Yes.
What do you think, Audie, what do you think is important for people who are considering that deep brain stimulation and have heard a lot about programming and are just so curious? What do you think is important for them to know?
Once they were advised by the neurologists, they have to follow up with what they said and advised to undergo DBS, most especially when you are qualified for this procedure, to consider this procedure with your right neurosurgeon.
And the right motor nerve
And
doctor.
The
right.
the right motor nerve doctor. I'm very confident you will benefit with this procedure. Above all, I thank God for my family, for their emotional support, boundless love, for helping me, directing to meet their intellectual, dedicated doctors who are among passionate well-being commended and thank them as well for they are the reason why I'm enjoying living life. Again, being appreciated and seeing the beauty of every little things that surround me. It is true indeed to live your life today to fullest. So we're still looking forward for what future holds.
It's reading.
As for me, I felt being useful not only for myself, but for everyone. This is certainly an awakening, life experiencing for me. Thank you for Dr. Joohi Jimenez-Shahed and Dr.
Right. I love that.
He constantly mentioning that to his friends, that without these doctors who are dedicated, very intellectual, and with a rounded family surrounding them, we are so lucky enough to find them, because we are blessed to have them, and we will be grateful forever as long as we live, for both of them, Dr. Joohi Jimenez-Shahed and Dr. Phinney, because they are not only intellectual, compassionate, they are a God's given gift to us.
Yeah.
Yes.
There are the angels, right, on earth, right?
Yes, that's true. Thank you for giving us this opportunity to tell everybody how good they are. They are really good. Fabulous.
Joohi, last question for you. After the initial programming, how do programming needs change over time? So he had a pretty great experience, 3 or 4 months, sessions, and what is the expectation over the next many years?
Yeah, so I guess, the part we didn't really get to touch on too much with Audie's case is that we were able to reduce his medications quite significantly. And so, what we expect to see with that is over time, it may be that the settings that we have chosen that are seeming to work really well right now may not be as effective anymore. And I think just like you notice some slow progression of Parkinson's even before the deep brain stimulation, we continue to see that Parkinson's progression. So it kind of makes sense that just like we adjust medications over time, that we're probably going to need to adjust stimulation over time. There are certain symptoms when they come back that will be easy to kind of fix again or control again with a stimulator adjustment. There are some that are going to be a little bit harder. And those are generally the things that become more problematic for patients in kind of the chronic, longer term phases of Parkinson's disease. So things like speech issues, swallowing issues, balance issues. These are sometimes things that patients will start to experience more of even after the DBS, and then those may not respond as well to the stimulation. So I think that, it's a great tool to have. And I think, when we're using it for patients who have already been using multiple doses of medications per day, having those dyskinesias, having those fluctuations, having that tremor that isn't getting well controlled, we expect to see those symptoms continuing to be very well controlled over time. It's just progression of the other things, and just a little bit of need to kind of adjust the stimulation over time gradually.
Yeah. So it's sort of the rest of it is just this balance of medications and stimulations, and more of one, less of the other, and just back and forth till you are finding the right settings and medication. But the fact that, you kind of got your life back right now, right? It's just things feel so different, and you're more hopeful. And now you feel like you have, some control over what's going to happen. That's really exciting. And I'm so glad that you found Dr. Shahed. She's pretty great. We like her around here. So we're very happy that you found her, and we're glad that you had a really nice outcome. So thank you so much for taking the time to talk to us today, Audie and Cora and Dr. Shahed. We really appreciate it. There's so many questions about DBS, and we really hope this helps our community very much.